All right, let's get started. So welcome to Core Insights. My name's Megan. I'm the new abdominal wall fellow at Cleveland Clinic in Ohio. It's nice to see many of the previous and future fellows here tonight. Tonight we're going to discuss ventral hernia repair in the contaminated field and approach to mesh infections. Tonight, our moderator is going to be Dr. Charlotte Horne. She is a abdominal wall reconstruction and minimally invasive surgeon at Penn State, and she's a previous fellow at Cleveland Clinic. And our presenters are going to be Dr. Aldo Fafaj. He is a current PGY5 at Cleveland Clinic, and he's going to be next year's abdominal wall fellow here. And our other presenter who's going to present some cases after this is Dr. Kelsi Swanson. She's a current chief at UT Southwestern, and she's going to do an MIS foregut fellowship starting 2023 in Allegheny Health. So Aldo, if you want to pull up your slides, we can start with your presentation. Aldo's going to start with reviewing some of the data around contaminated hernias, and then we'll go into the cases after that. And feel free to ask questions and use the chat at any time.
Can everyone see my screen?
Yeah.
All right. So I'm going to talk about some of the data with regards to ventral hernia repair in contaminated field. And putting this presentation, to me, it's kind of exciting because it's a unique perspective as a trainee to having witnessed a drastic change in the way we practice. Typically, the field of general surgery is slow to progress, but when it comes to ventral hernia repair in contaminated field, there's been a drastic change, and I'll go over it shortly with the data. So I have no relevant disclosures. So ventral hernia repair in contaminated field, it's one of the most challenging cases that the reconstructive surgeon faces. Currently, there's no consensus with regards to what mesh type to use, and there's a never expanding catalog of mesh options, all with limited data. So the surgeons often trying to figure out what's the best mesh and technique to use for their patients. And permanent synthetic mesh has been historically contraindicated. And this is mainly driven by the long-term mesh complication from the fear of chronic mesh infections leading to mesh explantations. Because of that, the companies have developed the biologic mesh, which are derived from biologic sources, such as human, bovine, and porcine, and the various body parts, they're mainly from dermis, but they can be pericardium and also intestine. And I won't go too much in detail with regards to the types and details of mesh. We have two previous talks. They're fantastic about the biology and the construct of the meshes, and all those sessions are recorded so for any new trainee that joins, I highly suggest checking out those videos, which are on the ACHQC website. But the basic gist of it is once this tissue gets harvested, they get processed, so all the cellular components are removed, and what's left behind is the extracellular matrix, which once implanted, it gets incorporated into the native tissues and promotes neovascularization, which in theory makes it resistant to infection. And because of this theoretical benefit, they really disrupted the field of hernia repair in the early 2000s. And they've gained a rapid uptake, not just in the US, but worldwide. And absorbable synthetics kind of bridge the gap between the two, the permanent synthetic and the biologics. They're at a lower cost than the biologic meshes. They're fully absorbable. However, most of the studies that have been done are retrospective, are in clean cases, and are singular arm studies. So I won't go into much detail with regards to these meshes. So the only guideline that we really have is the ventral hernia working group in 2010, when they gave some recommendation with regards to mesh usage based on the hernia grades. And if you look at the table 2 for grade 3s, which include presence of the stoma or violation of gastrointestinal tract, the recommendations of the permanent synthetic mesh generally is not recommended. There are some potential advantages to biological meshes. And for grade 4, the permanent synthetic mesh was not recommended. And again, they recommended biologic repairs. So in the early phase of introduction, there's been some enthusiasm with regards to these types of meshes amongst the surgeons. Surgeons have described the basic science of meshes, concluding that these are promising adjuncts to reconstruction of the complex abdominal wall defects. There have been some description of novel approaches to midline and peristomal hernias with biologic mesh and rectus rectus position. Also, description of a 5-year clinical experience with single-stage repairs in infected and contaminated fields utilizing biologic mesh. But what does the data really show? So in order to answer that, we should really start from a basic science perspective. And going back to 2012, 2 budding abdominal reconstruction surgeons, Dr. Blatnick and Dr. Kripata, studied this in rats. They operated in 283 rats, creating hernias and then implanting these 9 meshes listed below. The mesh was inoculated with MRSA, and what they tested at 30 days at after the study period was over, they tested for bacterial clearance. And if you look at the table, which is the main takeaway of the paper, the mesh that did the best was Marlex mesh, and followed by soft mesh and Prolite. So the authors concluded that polypropylene mesh did the best when it comes to bacterial clearance. And I'll come to Marlex mesh a little bit later. And Dr. Cole's group further studied the next step by testing the biologic versus synthetic meshes. So they used Stratus and ProGrip in 48 rats, and they inoculated the meshes with both E. coli and Staph aureus. And then again, they tested the bacterial clearance at 30 days. And if you can see in figure 3, again, the ProGrip mesh did significantly better in clearing the bacteria when compared to Stratus. But to me, the most fascinating part of this paper was looking at table 2 when they did some histological evaluation of the meshes once they were explanted. And if you look at it in the neovascularization, again, the ProGrip mesh did a lot better than the Stratus mesh. And this is part of the authors theorized that the bacterial clearance is better for the synthetic mesh because they're promoting more neovascularization. And then if you think about it, it's quite ironic because the neovascularization, it's the very basis upon which the biologic theory behind bacterial infection resistance is built upon. So it was quite interesting. One of the initial papers that described implanting synthetic mesh in contaminated fields was written by Dr. Carbonell, and this was the retrospective study from a prospective maintained database where retrorectus synthetic mesh was placed in contaminated field. And this was just a descriptive study. There's no comparative arm. So they looked at both the SSO and the 30-day SSI, and they described 7 recurrences and also 4 mesh removal. And to go into a little bit of detail, those 4 mesh removals are not, only 1 was entirely related to the mesh, 2 were due to anastomotic leaks, and 1 was due to stoma dehiscence. So I think it's difficult for us now to understand the impact that this paper must have had, but stating that synthetic mesh is safe to be placed in contaminated atrial hernia repairs might have been quite controversial at the time. But moving forward, there's been a flurry of more papers writing about the safety of synthetic mesh, and these are all retrospective data. There have been some systematic reviews and meta-analysis. Again, built upon poorly done studies, but they all center around the same theme. Using permanent synthetic mesh is safe, and they're associated with lower rates of postoperative complications. One of the main criticism of the Dr. Carbonell's paper might have been that the fact they only studied the patients for 30 days. So in 2020, they built upon their study and they looked at both their prospectively collected data from their registry, and after 2013, they studied the ACHQC registry. This was, again, a retrospective review of prospectively collected data. They identified about 441 patients. 245 patients had clean contaminated cases, 214 had contaminated, and 82 had dirty cases. And if you look at the outcomes of the paper, looking at the SSI, mesh removal, and recurrence, again, the same theme appears. More SSIs with biologic mesh, no difference in mesh removal, and also more recurrences when biologic mesh was placed. Now, this data should be interpreted with a grain of salt, despite being a retrospective and all the biases associated with this type of research. I think if you can see here, the permanent synthetic mesh is grossly overrepresented, which the authors do go into detail in the paper, and do mention that as a limitation. And the reason why I mentioned it is it expresses some bias with regards to the authors being more willing to place permanent synthetic mesh. And the majority of the biologic mesh was placed in the early part of the study. And that was mostly done in class 4 or dirty wounds, which can also be partly explaining the poor performance of the biologic mesh. Dr. Fisher, 1 year later in 2021, published this systematic review and meta-analysis where he identified 17 papers. And after their meta-analysis, they concluded that absorbable mesh, which they included absorbable synthetic and biologic, had worse outcomes when it comes to hernia recurrence, SSI, and SSOs. And the authors of the paper concluded the use of the permanent synthetic mesh may be a safe alternative to absorbable mesh, and additional prospective randomized controlled trials are warranted. And thankfully, they didn't have to wait too long, because the following January, Dr. Rosen's group published a biologic versus synthetic mesh for single-stage repair of contaminated ventral hernias. This was a randomized controlled trial where they enrolled 253 patients, looking at recurrence at 2 years as the primary outcome, and also morbidity and quality of life as secondary outcomes. If you look at table 3, now you can see there's no difference between the groups when it comes to SSO, SSI, and then also SSO requiring procedural interventions. The only difference was when it comes to recurrence, the biologic group had significantly more recurrences when they're compared to the synthetic group. The percentage was the recurrence with biologic mesh was 20%, and the recurrence with the synthetic mesh was 5%. And you can see the Kaplan-Meier curves for both of those groups in figure 2. The authors concluded that synthetic mesh demonstrated superiority to your hernia recurrence risk when they're compared with the biologic mesh. So part of my job was to come up with a guideline with regards to ventral hernia repairs in contaminated fields. And there's really no guideline currently that we can use. I think what we have is we have a collection of data. We have this data ecosystem. Then I think rather than be confused by it, I think surgeons should use it to tailor their practice to fit the best type of mesh for their patients. And is this data enough to say that we should not use biologic mesh? Not necessarily, and as is often the case in hernia surgery, the answer is not as simple as that. There's now growing evidence that permanent synthetic mesh is safe, but can we say that everybody should be using it? I'm not sure that that's quite prudent. One thing that retrospective studies are good at is answering a specific question and doing their best to eliminate biases. So that biologic versus synthetic study was done by fellowship trained surgeons in a very basic clinical practices. So in one way, the study is good because it puts both meshes in the best hands, and you're basically giving it the best chance to perform as well as they can. But that does not necessarily mean that everybody should be using it, because when you get highly specific with these studies, that you tend to lose external validity. So it's really important to stress technique and mesh selection with regards to who the surgeon is and who the patient is. So rather than making a blanket statement, the surgeon should really look at themselves and their practice. If you're a surgeon that was using permanent synthetic mesh in contaminated fields, there's now level 1 evidence that that's safe to do. But on the other hand, if you're a surgeon that is using biologic mesh and has good outcomes, I'm not necessarily sure that we should say that we should switch to synthetic mesh unless you track the data. So we are not ready to have the conversation if the surgeon is not tracking the data to see where they're starting. So I think the next step is to compare different weight meshes in contaminated field. If you go to that first figure that I showed, the mesh that performed best was Marlex, and that's heavyweight polypropylene. So I think it might be time to compare different weight meshes when it comes to contaminated field, given that the animal studies are an indication that they might not perform as poorly as is once thought. And also, I think it's time to look at durable synthetic versus permanent synthetic mesh in a more randomized controlled trial fashion, and then prospectively. We talk about recurrences, we talk about SSO. I think that's all important. But to me, the most fascinating thing about this paper is these two figures. It's the quality of life. The group used two different questionnaire measuring the quality of life. The EQ5D, which is just general health quality of life, and also a hernia-specific Hercules. And for both of these, higher scores means better quality of life. And if you look at it, between the two groups, the graphs are virtually indistinguishable. So at the end of the day, the higher recurrence in the biologic group didn't really matter. Both groups did well as measured by a hernia-specific questionnaire and also a general health questionnaire. So I know as surgeons, infections and recurrences are important. Those are, that's what we care about. But when we go back and ask patients, those recurrences didn't matter. Everybody did well, despite which type of mesh they used. So I'll leave it with this. I think perhaps the time is now to, rather than focusing on things that only matter to a surgeon, is to use the quality of life as a primary outcome, so we can answer questions from the study that not only matter to us, but also to patients. Thank you.
Great, amazing. Thank you very much. Does anybody have any quick questions right now, or do you have any comments, Dr. Horne, anything?
Yeah, sure. That was a great presentation, Aldo, and I think a really good summary of sort of where we're moving with mesh and contaminated fields. And I think, as we start to, understand mesh a little bit better, understand how it interacts, we can be a little bit more aggressive. And I think, one of the tricky things is, everything is contaminated, but like also how contaminated, because sometimes you are leaving a stoma up and sometimes you're moving it. And sometimes you're redoing anastomosis. So I think, in terms of like a surgeon's preference in their practice, it also kind of depends on like the degree of contamination that they are comfortable with. And so, I think shockingly, from the experience in Cleveland, super aggressive with a polypropylene piece of mesh in a contaminated field. And I think there's a lot of evidence to support that. That being said, I really still don't think it's actually the practice of most surgeons across the country. And having been on a couple of conferences, people would prefer to put in a biologic or stage a repair if there's, anastomosis to be done to avoid a permanent synthetic in a contaminated field. It's really interesting to see how these, some bioabsorbable, more synthetic-like meshes perform in these situations. You mentioned we don't have data, and that's true. And I think as we start to understand more about it, and also as mesh companies start to bring other alternatives, we know that it probably doesn't last or last longer than the 18 months that they said it did, but that's the tensile strength that it's, I guess, guaranteed for. So understanding how those will perform in contaminated fields is exciting and an opportunity for people that maybe are not as comfortable with the synthetic. And I think, even if you put a synthetic in and it does get infected, there's still a ton of data from that Cobb paper that you said that stuff is salvageable. And so, yeah, there is, it's cheaper to put a synthetic mesh in for sure. There is some overall cost to dealing with a wound infection, but in general, actually, it's probably, does better long-term than a biologic. And there's certainly a lot of data as you presented that it's safe and effective to do so.
Yeah, I think once you introduce the cost, I think things get a little bit muddier with regards to being cost effective. It's not just the upfront costs with regards to the absorbable synthetic and the biologic, because it's no comparison. You have $100 piece of mesh that you compare it to a $20,000 or more piece of mesh, or even for the absorbable synthetic, it's still quite a considerable cost, $3,000 to $4,000. So once you get the cost of the mesh, it's hard to, there's no comparison, but you also have to look into effectiveness. If the absorbable synthetic prevents a take back to the OR, or if it takes multiple trips to the operating room, or prevents a wound vac placement, that may be offsetting. So if those are things that we just don't know yet, I think we're still in the infancy in understanding it, but you do raise a good point.
Aldo, I got a question for you. So you've heard us kind of lament the design of Mike's trial on the back end as we learn more about trial design, and kind of going off what you just said, that cost is such an issue. If we were to ever, redo this trial or compare synthetic to absorbable synthetic, Phasix obviously is kind of the new kid on the block. If we were ever to do that trial design, what would the design be? Whether the outcomes, quality of life or recurrence, and why?
I think, first of all, like the main design flaw for this paper was set up as a superiority trial. So if you're looking at recurrence or even wound morbidity, if you're comparing, again, a piece of mesh that costs $100 to one that costs $20,000, it doesn't have to be better, right? It should be non-inferior to the more expensive mesh. And therein lies part of the problem, because the increased cost when you're doing this trial, the new mesh that you're testing, whether it's the absorbable synthetic or the biologic, has to beat the permanent synthetic by a lot. And that's really hard to prove, given how expensive they are. I think once you get the cost out of the picture, I think designing it with quality of life as a primary outcome, I think might be the next frontier, because at the end of the day, who cares that the biologic group had 20% recurrence? We care, but patients don't. They still did well. They still did just as well as the permanent synthetic mesh people did. And if I showed you those two graphs as the primary outcome, your conclusion would have been totally different. You would have said there's no difference between the two types of meshes. So I think moving away from things that are data-driven and important to us, and more towards the quality of life, again, might be controversial this time, but there might come a time, and maybe now it's a good time to start, that might be the thing that we care about and we measure.
I think it's really interesting as you have also published data now with bulges and how it might not be, or there's a spectrum of recurrence, that those people had worse quality of life, but these people that we know have a high recurrence rate had no difference in quality of life. So I think that also sort of muddies like what exactly provides somebody like quality of life. And I think, especially in these contaminated cases where they're all, or if the overwhelming majority are peristomal hernias, is like, how is their quality of life different than like people that don't have a peristomal hernia? Because obviously if you have a leaky pouch, going from a leaky pouch to a non-leaky pouch, whether or not you have a recurrence is an improvement, versus if you aren't even dealing with that to begin with, you're probably a little bit more picky about your outcome.
Yeah, and I think looking at the recurrences, most of this recurrence were assessed via CAT scan or clinical examination. There's only a small percentage of patients that were measured with the ventral hernia recurrence inventory. I think those may be a little too sensitive to measure recurrences. You may be picking up small recurrences. Then again, they don't matter to the patients. They may not even be aware they have it. But when they're reviewed by the blind reviewers, they're counting as a recurrence.
I have one more comment about the quality of life. Like in these studies, whether you got biologic or synthetic, like almost 2/3 of patients had some sort of morbidity after the surgery. And I'm just wondering how that affects like patients' choice to undergo a single stage operation versus undergoing 2 major operations, but turning a contaminated case into an uncontaminated second stage hernia repair.
So a large portion of these cases were peristomal hernia, so it's kind of difficult to stage those repairs. But I think that's just an answer. We don't know how those, one surgery versus 2 surgeries compares. I don't think we know the answer to that just yet.
Do patients generally say like, I want to go ahead, I want a single stage operation, or do they say, no, I'd rather have 2?
I think in my experience in the hernia clinic, the patients will agree to whatever the plan that you have. By the time we see them, it's been the end of the road. They've seen multiple surgeons. They're finally agreeing to what you have to offer. And I think it's important to kind of offer, both sides of the spectrum and present the data as we have collected. And I think we do a very good job of that.
I think you're onto something though, Megan. I think that that in terms of thinking of the next trial of like how would you design this, I think more often than not, a lot of those cases can be staged, and the important thing that Aldo alluded to was we're always asking what's going to be different next time. And so for a peristomal, it doesn't matter because the stoma is going to be there the next time. But the Hartman's reversal, the cholecystectomy, the hysterectomy, a lot of those cases, if you stage them, they're clean cases the next time. And so the problem with that is that it's such a hard thing to study prospectively, because capturing the cost from 2 separate operations and all those hospital stays and trying to figure out from the patient's perspective, which experience was better can be very challenging.
Well, and I think you also have to look at the economic to the patient, which is very like individual. Like for some people, for them to, we're asking people to take at least 4 weeks off of work. They have to travel to come for surgery. They have to have family come and care for them. And so for those people who are in a situation where they're the providers for somebody, of course, they're going to want a single stage because it's such a huge undertaking for them to actually just get surgery to begin with. And so when you ask people to do that twice, that's it's a huge financial and economic impact to the patient. And I would say, like in my practice now, I'm shocked at how hard it is to get people to like you really understand what the impact is of like a delayed surgery or cancellation because of COVID or something like that, that like the overwhelming majority are like, listen, like if we could do this in one, I have to do that because I can't take time off. I can't, do this again another year. And so I think, that's very, very important, but also extremely challenging to actually study because it is very patient specific.
Agree. All right, it's 8:30, so let's go on to the cases. Kelsi, if you want to pull up your slides.
Yes. No peeking. Okay. We all know why we're here. So first case is an 80-year-old female with past medical history of CHF, AFib, not on anticoagulation, ESRD on HD, and intermittent home oxygen requirements. She has a long-standing ventral hernia for about 30 years, and she was seen in a clinic to see if she could get an elective repair, but she needed preoperative clearance prior to elective repair, and her PCP was unwilling to clear her. She presented to the emergency department with 3 days of nausea and vomiting and progressive abdominal pain. Her only surgical history is C-section. Did not write her BMI down, but it's high mid-30s. So on physical exam, she has a large hernia in the lower abdomen, but most prominent in the left lower side. There's significant skin attenuation and it's firm and tender. CT scan, I'll pull it up as well, but the dilated segments of small bowel with a transition point suspected within a large left paramedian ventral hernia, which contains colon and small bowel, and she has a trace amount of ascites. So here is her scan. Go through it again, or you all saw it?
Oh, you can keep going.
Okay. So intraoperatively, large hernia sac, it contained small bowel, right, transverse, and sigmoid colon, so quite a bit. Then she had a small area of focally perforated small bowel without gross spillage, but there was some surroundings area of non-viable small bowel that needed to be resected as well. So then kind of discussion time, what we'd do for that case.
Aldo, what would you do?
I'm sorry, I missed, she came in, she is obstructed?
Yeah, she was obstructed. She presented with 3 days nausea, vomiting, and then she had some small bowel that was not viable with a focal perforation, not frank contamination, but a little bit when we got that adhesion
So
down.
for her, I would do a small bowel resection and do a primary repair of her hernia. I would, the way at least the way I look at this, you kind of have to separate the bowel problem from the hernia problem and address what she came in. She came in for a small bowel obstruction and bowel ischemia. So just do the resection, do a primary repair, and have her, let her develop a hernia and then come back electively to fix it.
Dr. Petro, would you do the same?
Yeah, I agree. I'll say, not to say I would never do a definitive repair, but I would say unless, it was super straightforward, very clean resection, patient's totally stable, it's the morning, we don't have 10 cases to follow, 9 times out of 10, it's going to be bowel resection, primary closure.
All right, what happens if there was no contamination? Would you do the TAR then, or retrorectus, or would you still stage it?
So if it didn't perforate and it pinked up and I wasn't worried about any like kind of transmural necrosis or delayed necrosis or anything like that, if it was just like transiently ischemic and it pinked up, I would be much more likely. I would go from like 10% chance to probably like over 50% chance that I would just do a definitive repair.
What kind of are you weighing in your mind when you are thinking of, hey, I'm going to do, I like to call them the acute TARs, acute TAR versus a staged operation?
Yeah. So I'm thinking of this as she's older, right? She's older with CHF and AFib. I mean, a laparotomy in her, and the type of recovery for her to get through this operation is not a whole lot different, whether it's it's a full-on laparotomy, primary closure, or TAR. Like the difference between those two, in my mind, is not dramatic, as opposed to if I close and obligate her to a future operation that's similar. So, you know, that's one thing. And then again, I always ask the question, what's going to be different next time? And for her, if she's not perfect, it's a clean case. You know, as long as the bowel's not horribly distended and I can still get the fascia together, I'll probably just be more likely to go for it.
Okay.
Dr. Cervoni, what about the fear of translocation? Is that a thing? Is that?
Yeah, I'm assuming you can hear me. So yeah, anytime you have an incarcerated hernia, there's going to be some edema. I always worry about translocation and the surrounding tissue of the obstruction. So with any of those cases, I would try a primary repair. You know, take care of what you have to take care of with the bowel, even if the bowel wasn't ischemic, and even if I didn't have to resect or have an enterotomy. Depending on how much edema was surrounding the tissue, I would choose not to do a primary repair, but rather I would choose not to do a mesh repair, but rather a primary repair somehow. You know, and as I'm listening to the discussion, you know, what if it was such a large defect that I wouldn't be able to close primarily? So I think in that setting, you know, I would probably do something in a retrorectal space. Obviously, I wouldn't do an IPOM, which would have a less chance of infection even with prosthetic mesh. But again, I would hesitate to put in a mesh, even with incarceration and without interruption of the small bowel in an incarcerated emergent hernia.
So I'm just going to follow up with that. You can't get, the defect is so big that you cannot get the fascia closed. You decide to do a, you know, you had mentioned a retrorectus repair. What mesh are you choosing and why?
Well, in that setting, I have used a long-term absorbable, Phasix or a BioA.
And then why is your preference especially when you know there's a pretty high likelihood that you would be coming back for a hernia? Why do you choose, like, why is your choice of retrorectus versus maybe a small bridged repair?
Because I'm less likely from experience to have to go back with a retrorectus repair as opposed to just an IPOM.
All right, Kelsi, keep going.
You want me to tell you all what we did or just move to the next case?
No, tell us what you did.
Okay, so she actually, because this hernia had been out for so long, she had a little bit of loss of domain. She had some incredibly redundant colon by some of that ileum, so she ended up getting a colon resection as well. We did leave her in discontinuity because, like I said, she's ESRD on dialysis, CHF, wasn't doing well for a couple of days, so she ended up being left on discontinuity, going to the ICU and then going back eventually, and then she was closed primarily with one non-looped PDS. Okay, next. Second case, so we have a 39-year-old male with a history of gunshot to abdomen, status post-exploratory laparotomy with a transverse colostomy. And then about a year later, he was status post-reversal on 5/16/22, and then he had an anastomotic leak requiring take back to the operating room. He had a CT scan on the 19th with a gas-containing fluid collection, which measured approximately 10 by 8 by 4, which was distinct from the adjacent bowel. This is his scan. I believe his BMI was around 34, 35. This is a picture of the posterior portion of the anastomosis. There's about a 1 centimeter defect there. So he had some turbid fluid and hematoma surrounding the anastomosis, about 500 cc's, and then 1 centimeter breakdown of posterior portion anastomosis. So I broke this down into 2 scenarios. So plan is for a section and then diverting ostomy and closure. How would you guys plan to close? As you saw it from the CT scan, there's a pretty big defect in the fascia, and it was sitting in some murky fluid hematoma, so it's a little bit angry.
Dr. Parnell, how would you close?
I feel like one of the most valuable things I learned last year at the Cleveland Clinic was how to use a good figure of 8 on the fascia. And it was surprising to me how many big hernia defects came together primarily with some interrupted figure of 8 sutures. So that's what I would do. I would bring up an ostomy and do interrupted figure of 8, snap each one, and then at the end pull them all up together. And it's amazing how many big defects you'll pull together that way.
And if it still won't come together?
Then if it still won't come together, then I would do a bridging vicryl mesh in this scenario. So I wouldn't place permanent synthetic. We'll be coming back later. It's a dirty, pretty infected case. So I would bridge it with vicryl mesh.
And then what do you do over top of the vicryl mesh? Like, obviously skin is best, but what if you can't get the skin closed? That's definitely a difficult situation that you would want to plan for, and that you hopefully don't find yourself in without, like I said, planning for. So in that CT scan, like, I don't feel like the skin closure would be a problem with that one. If you are in a scenario where you do think you'll need a vicryl mesh and some type of skin closure, then you just need to talk to plastic surgery beforehand and plan on a flap.
Yeah, I would say either, sometimes they probably obviously will not flap something that kind of seems to be grossly infected, but an early consult to plastics is very helpful, because what probably the best situation is get at the vicryl, get some granulation tissue on it, and see if they can skin graft over top of it like pretty soon after. In general, like, getting the fascia closed can be challenging, but the soft tissue coverage is something that you always have to consider before you go back to the OR, because that obviously involves a lot more planning. You have to get plastics on board. So the lack of soft tissues is a much bigger problem than I would say not getting the fascia closed.
So Charlotte, have you experienced where, like if you have to bridge with a vicryl mesh and you have a big area of skin that's not going to come together? I guess like you leave a wet to dry, and how long, plastics is going to want to wait for some granulation tissue. How long do you wait and hope that a fistula doesn't form versus getting that skin graft on fast?
Yeah, so I think the trick is always keep the vicryl as wet as possible. And so that can kind of prevent against any sort of like the vicryl drying out, and that's normally what causes the fistulas. In general, I think always close as much soft tissue as you can to minimize the stuff that is exposed, and then as soon as you can get granulation tissue, you kind of need an aggressive plastic surgeon, but that can be done. There's all these like new wound vacs that can kind of help protect your soft tissue. But I think sometimes when you're looking at a big defect like that, the tendency is to say, hey, there's no way I can get this together. I'm going to just do a huge bridge. And in reality, probably the best thing, as you mentioned, is use the figure of 8s as much as you can to make the bridge or make the defect as small as possible. And that's the same thing with the soft tissue, to try to minimize the amount that's actually exposed. And you truly can get a lot together with a figure of 8. I kind of also tend to, because we have a little bit more, we use phasics a little bit more here, I kind of stratify my people as to, is this somebody that I will be operating on again in their lifetime? then they will get a vicryl. If this, let's say I have, a big hernia and a BMI 70, and I never ever think that they're going to be like a definitive candidate, then those are the situations that I will use Phasix in, just because it does last a little bit longer. It is a little bit stronger. And I am not planning on going back in there in the lifetime of the Phasix. So that's sort of how I've incorporated Phasix into my practice if I need to use it in a bridging situation.
Okay, so sorry, that was a discussion slide for that. So scenario 2, we leave him in discontinuity with bowel resection as an Sarah. Your plan during take back. I imagine it's probably the same for most people.
Would anybody do something definitive on the take back?
Why are we leaving the patient open?
He had some frank contamination, and then they wasn't in the take back, but I think that, so he was in there long enough because from his previous GSW, they also had to mobilize a lot to bring up an ileostomy, and then just with the frank contamination with those two things, OR time and being there that long, they want the second look.
I wouldn't do anything definitive here. I would still just try to close the fascia primarily.
Yeah.
I agree with that. This patient's still going to need an anastomosis and a loop.
Well, and I think to Aldo's and Dr. Petro's points on this call, when you take a look at this patient, the question is what is going to be different next time? The next time you're not dealing with an anastomosis that had leaked. Obviously, you're making a new anastomosis in a situation where something has already leaked and they have a new stoma. So those are all of the things that you're thinking about as you're trying to plan a repair or stages of repair for this person. And so clearly the next operation after he's recovered from this is going to be a much better situation. So not doing anything at this time other than just, a primary repair is completely reasonable.
So for him, he ended up, when they were trying to close his fascia, the sutures were kind of ripping through just because it had been sitting relatively close. He didn't have momentum to really cover that anastomosis. So it was sitting relatively close to his fascia. So it was ripping through. So he ended up getting a bridging vicryl mesh and then a delayed primary closure a couple weeks later of the skin.
I would like to ask a quick question about the vicryl mesh. I had a similar case recently, and when it was time for me to use it, it came up a question that I never thought about it before. When you look at the shelf for the vicryl mesh, you have a woven version and you have a knitted version. When you guys use it, there is any preference for one or the other? Is there any concerns about the vicryl mesh one or the other when exposed directly to the bowel with fistula formation or anything like that? I would like to hear the experience of you guys.
That's a great question, Luciana. I don't know whether we use the woven or the knitted. We just asked for vicryl mesh. And does anyone know which one you typically uses? I suppose I could Google it right now. I feel like I know it if I saw it.
The nurse brought to the room both of them and say, which one you want? And I said,
which one looked like the one that we use?
I think the one I saw you guys using before is the knitted one that looks more like a polypropylene mesh. I think the woven one looks more like a more homogeneous layer where it can barely see holes in between the fibers.
No, that's the one we use then, the woven.
Yeah.
Yeah. Mm-hmm. And the thing that's nice about, both of them, even the one that's really more laminar, is they both are permeable. And so a lot of times people will ask, why not use a BioA or a Stratus in that type of situation, just to give something a little more sturdy. And the thing that I love about vicryl mesh is that it's permeable, and I think that prevents fluid collecting both on top of the mesh and underneath it. And you can kind of peek, if you do get in a God forbid situation where you're staring at the vicryl mesh because your sub-Q broke down, or you have a wound infection, you had to open up the sub-Q and you're looking at your vicryl. you can look through it and eventually you can see when there's granulation tissue underneath it, and you could just trim the micro mesh out in order to graft on top of it, you know, after a month or so. The things that, you know, people don't like about micro mesh, I think are great.
Got it. Thank you.
Mm-hmm.
Okay, next one, and we'll call this the last one. We have a 40-year-old female with multiple medical problems and diastasis with a past surgical history of multiple bowel resections and abdominal surgeries. I've listed them below. She comes into clinic. She's kind of complicated, and she has an exposed mesh and succus coming out of her midline. So she has a fistula. She's had multiple surgeries in 2019, multiple leakages. This is her midline, right around where her umbilicus used to be. And then her CT abdomen and pelvis, she has evidence of prior small bowel resections. So it looks like she basically has an anastomosis adherent to the midline. And then she has subacute gas and debris. So suspicion for a fistula, but there's no leakage of contrast. She had been trialed on TPN, and then prior to surgery, she was able to actually take some Ensure and get some enteral nutrition as well. After she ended up coming to our institution, they restarted her oral intake. This is her CT scan. This one goes a little bit fast, so I can go back again after it stops playing. So,
BMI was what?
I can look that up. I think she was like a 32. Let me look that up while y'all discuss.
Nutrition wise?
Yeah, her nutrition was significantly improved, and she was taking some PO as well. So her nutrition labs were not terrible.
All right, Dr. Parnell, you see this patient in clinic week 2 of your practice. What are you going to do?
Quick clarification. What mesh repair did she have previously? How far
I did not have that information.
So we're not sure how big that mesh is. Okay. Well,
It was at an outside facility.
okay. Well, this would be a stage repair for me. She looks like she needs to lose some weight. So I don't see an urgency to her case if she's not, you know, sick, febrile, acting clinically like she needs to go right away. I would have her lose some weight, and then we could schedule something electively for me to remove all of the mesh. So I would just do a laparotomy, clean it up, take out all the mesh, and that would be her first stage of the operation. Then try to close her fascia primarily, and then I would plan to see her back later for a definitive repair.
Dr. Petro, would you do the same?
Yeah, I mean, I'm a lot more lenient for people with fistulas. Like BMI in the 30s, even if it's 38, 39, I'm sympathetic to these things are miserable. These people are miserable. I'm not putting mesh in, so I don't care about she could be smoking 2 packs a day. Like I don't really care. I'm just gonna get rid of that fistula for her. Her quality of life will be so much better. Now for the second operate, the more definitive one, when she comes back with a hernia recurrence, absolutely, then you can be a lot more rigorous in terms of weight loss and comorbidity management. But for these people with the fistulas, these people are absolutely miserable. That's not the biggest defect in the world. That muscle's going to come together just fine once you get all the infected mesh out and do a nice bowel resection.
Mm-hmm. Do you have a BMI? So you have somebody that has a fistula that's like sort of eating on and off TPN. Do you have a BMI cutoff for those people, or do you say, kind of wherever you're at, we'll take out the mesh, get you all closed, and then work on weight, other comorbidities when you are ready for the definitive repair?
In terms of, were you asking about like nutrition parameters?
No, like you have a BMI 45 person or 47 come in and they have a fistula, they're on TPN, and you're like, hey, I need you to lose weight. Do you make them lose weight, or do you just offer them the fistula takedown?
Yeah, if you can't heal a small bowel anastomosis, that just like, I mean, whether it's TPN or no TPN. And now, again, you got to weigh everything. TPN is not a benign thing. These people can be in and out of the hospital with line infections. They get a DVT next to their PICC line. Now they're on anticoagulation. They're dumping out of their fistula, so they're nutritionally depleted. And so like, sometimes you just have to look at the whole picture and just make an assessment of, I had a lady just like that who, she's on anticoagulation, she's on chronic antibiotics because her PICC line's infected. She's in and out of the hospital every other week. And sometimes you just look and go, if this fistula just wasn't there. Now, granted, you still don't rush in, you give it time. I'm not talking about going in, 3 months. I'm giving it time, but the grand scheme of things, if they're a year out from all their old surgery and really at the end of the day, their main issue is just that they have this high output fistula and it's just a small bowel anastomosis. Now, a colonic anastomosis or something more in the pelvis can be a little different, but if it's just a small bowel anastomosis, I think sometimes you just got to bite the bullet and go for it.
Yeah, I agree. Those are like, they're challenging conversations to have in clinic when they're obviously like dealing with, various amounts of wound management, TPN, nutrition, and stuff like that. I think the biggest like conversation about weight loss is if you think that, they're kind of in a loss of domain situation where you need all of the room to get stuff in and get stuff in safely, then that's a little bit different. But I have found myself a little bit more aggressive about operating on people that have fistulas, simply because you're right, the quality of life is so poor for these people. And a lot of times, getting rid of the fistula, they're super willing to, quit smoking, lose the weight, all of that stuff, because now they like aren't dealing with a lot of the reasons that were barriers to weight loss previously.
And her BMI was only 33. I looked that up again, so kind of low. But I think that's a challenge too when someone's like on TPN. So she was on TPN when she came to clinic, and then she ended up taking some Ensure and a little bit of PO intake. Just how are you like, oh, you need to lose weight? Like one of the things that people can do to lose weight is modify their diet. And it's like, well, I'm getting all my nutrition by vein, and then I can't exercise because I just have fluid leaking out of my belly. I think that's also a really difficult discussion to have with those patients as well. Like they're at a loss already, they just don't know what to do. So.
And I think if you're just honest with them and you kind of explain the stakes and explain the risks and, then say that, hey, listen, the worst thing that could happen, and you'll probably be right back here where you started, with another fistula. But like I said, again, small bowel anastomosis, if you're careful and you just take your time and do it right, it should be worth it.
Yeah. So does anyone else, do you guys want to know what we did, or does anyone else have comments?
What'd you do?
So she ended up getting a fistula takedown, obviously, with a small bowel resection and anastomosis. She had a component separation and then a biologic mesh placed. She did pretty well with that. She just had a little seroma afterwards. The plastic surgeons ended up taking care of that because they came in and helped. This is one of our general surgery attendings that did it. And she's pretty happy.
Yeah, I mean, I think that's a situation where, again, this is what will be different next time. Next time would be a clean case. If it goes well, it's awesome. But if it doesn't, it's one of those things where you look back and you realize that if you had just gone for a base hit, that you wouldn't have like burned the retrorectus space, so to speak. So I think those are the times when everything goes great, it's awesome. But it's the time when things don't go great, when you look back and you go, shoot, I burned my bridge.
Dr. Petro, quick question.
Yeah.
I believe I did one of your patients before I left there, and she was BMI 50. She had infected mesh. She was chronically draining from her umbilicus. And I took out all the mesh, cleaned it up, closed her primarily, left the skin open, wet to dry. And that wound took like 2 months to heal. And I was starting to get worried that like eventually her fascia was going to open with her BMI of 50 and her wound is still trying to heal. Ooh. So yeah, like, do you have any advice, you or Dr. Horne or anybody, on, I guess that was my thing on, like, is there a BMI cutoff that you're worried about that? Or do you have like tips and tricks? I used a vac on her, and I think some of the superficial aspects of the wound healed before the deeper parts. So I had to open it up like 5 times in clinic to get that seroma to, like, oh my gosh. Thank you for your parting gift. So that's why I'm like, should we have them lose some more weight so I don't have to deal with this wound problem, you know?
Yeah. Yeah. I mean, like, was that one of those people that had been trying to get to lose weight for like 3
You did, yeah. But I'm glad I did it. She was super thankful and happy, and her
Yeah.
wound finally closed, and she's fine. But
yeah, I mean,
Yeah.
listen, these people need to understand, like, when you get in the BMI of 45 to 50 range, I mean, you just have to, as long as you're honest with people and explain to them that, hey, listen, this is like way out of the realm of what most people would be willing to offer. And if I do this, like, it's, bad things can happen, and it may be a long road. But like you said, like, she probably eventually got over it. It probably took a couple debridements. And if you're honest with people up front, like, she's probably happy that she went through it, even though it wasn't easy. But you just have to be honest with people, and as miserable as it was for her on the back end, she's probably glad it's over, and she did it.
that's true. She is.
Yeah.
Yeah, so I think I'm super aggressive about actually closing skin. My partner uses a whole bunch of wound vacs. I don't, for a lot of reasons. Number one, people don't actually have insurance to cover wound vacs here. So like, if I am putting a wound vac on and committing them to that, it means like I'm changing the wound vac in clinic every Monday and Thursday, which is terrible. And so my sort of preference, because of just like practice patterns here, have been, I would probably vertical mattress the skin and wick it instead of leaving it open, just because you'd be shocked at how much actually will come together. If you're super concerned about a deep space, then sub-Q drains can be helpful because you can kind of leave those in a little bit longer. But honestly, I have operated on BMI 50 infected mesh, and close the skin tight, and it's shocking how much will actually heal. And yes, I've had to cut out some sutures, but then you're actually like only having to deal with a small amount of space. So I think it's okay. I will like wick them, and honestly, we'll change the wicks until they leave the hospital, and then and leave the sutures in for a month. And I, have been shocked away with what I've gotten away with. But I think, again, always trying to minimize the actual exposed. You'd be surprised at, what these BMI 50 people can actually heal. And then you're not dealing with a big wound and wondering about all your fascia stitches. It's like 4 or 5. So.
Great. Amazing. Thank you. I'm just conscious of the time. I don't want to take up your entire evening. So that was amazing. Thank you, Dr. Horne, Aldo, and Kelsi. Those were excellent presentations, and the discussion was as good as it always is. So next month, second Monday of the month, we're going to discuss ventral hernia repair in the comorbid patient. What are the risks and how to counsel these patients? So see you all next month.
Thank you.
Thank you.
Thank you.
Thanks.